Hi there, Sarah Trim here, birth doula, childbirth educator, photographer, bartender, art education, you name it. So this is week 2 of my childbirth education series. So I'm really excited about this week because my boyfriend helped name this week, Are We Educated? And what that means is, are we informed? Do we have the knowledge? And are we educated about all of the interventions that can or can't be done in labor, right? So when we let the body do everything naturally without any augmentation of any sort, that's called a physiologic birth versus pathology or pathologic. So pathology is like the study of like when there's something wrong with the body, and physiology is more of letting the body do things naturally. So you could have a view on this. You might not have a view on this at all. A lot of women just show up to the hospital and they want to just be led to be told how this is going to look and just get the baby out. You know what I mean? Because a healthy, happy baby is what everybody cares about. But at the end of the day, I really care about mom too. Because as a doula, my client is not the baby, my client is the mom and the partner. I want to make sure that you have as little trauma, as satisfying of an experience as you can possibly have. And I want whatever you want, because before I became a doula, I had a lot of naive, I was very naive about this is what I want. This is how I'm having my baby. I want low intervention birth. I don't want any interventions. I don't want to be induced. I want to go into labor naturally. I don't want an epidural. Like I had a lot of birth preferences. Like I had a plan, right? And so as you become a doula, you learn that nothing goes according to plan. Birth is probably the most unpredictable thing you can plan for. And so you can have birth preferences. And so I'm hoping that this class today will help you develop those preferences, kind of get an educated, evidence-based foundation to learn all about induction and membrane sweeps and cervical checks and breaking your water and all these things that can happen that are actually your decision. And that, I think, is the most important, is that when I was pregnant with Monroe, my mom told me, oh, well, they're just going to do this, or, oh, they're just going to do that. And I was like, no, they're not. Oh, they'll just cut you and give you an episiotomy. Excuse my French. The hell they will. They're not. No. You can consent or say no to as much or as little as you want in birth. And I want you to know that because, like I said in the beginning, a lot of women just show up and they're like, all right, just tell me what to do. But if you're watching this video, I feel as though you want to know a little bit more and you don't want to just be led down a path. You want to be informed and educated. So, are we educated? Today, we're going to get schooled. I'm just kidding. So today, we're going to talk about medical and natural options with everything, okay? Whether that be pain management, inductions, cervical checks, something they call failure to progress, and then the acronym B.R.A.I.N, B.R.A.I.N, which is an acronym I use to help people make decisions. So, the role of the doula, I just want to say this right away. None of this is medical advice. Anything I discuss, you need to make sure you discuss with your doctor, because even though I was very low risk, every pregnancy, every birth, every person is different. And so what applies to me or to you might not apply to someone else. So I'm not here to demonize any of these interventions. I want to give the evidence on them. I might give a little story or an opinion, but all of these interventions are rightfully so like medical procedures, medical options. You know what I mean? So, what was not needed for me, you might need. You know, there might be a medical, a, nece- a necessary medical reason to get induced. Whereas for me, it was elective. I was consenting to something that I really didn't need because there was no medical reason. So we'll get into that just a little bit. But the role of the doula is to provide physical support, help with comfort measures, mental support to reassure you and your partner, yes, this is normal. This is what birth looks like in the moment. When you look around the room and you're like, oh my God, is there supposed to be blood coming out of there? Or is this supposed, or why is my partner like doing this or that? It's okay. This is normal. She's puking because she's in transition, little things like that. So informational support. So that's something a doula also does, is evidence-based care. And so that you can understand your choices. And then advocation. Doula does not advocate for you. I don't tell the doctor what you want, but I'm here in the moment to say, hey Sarah, remember, you wanted immediate skin to skin. Do you want to take off your thing to do you want to take my doula was like, do you want to take your bra off so that you have immediate skin to skin? And I was like, oh, I thought I could just put the baby on my chest with my bra, but whatever, you've already seen it all anyways. So the advocation part is cool because it's going to remind you of your preference and help you advocate during birth, because when you are in labor la la land, you are not thinking about the things that you wanted, and the things you wanted maybe have changed, or you don't care about them in the moment because you're just like, oh my God, there's a baby on my chest. I don't remember that I wanted to delay the cord clamping, stuff like that. So individualized evidence-based care is huge for me, because when we're becoming educated about birth, say you go to an OBGYN practice that has 4 OBGYNs and 2 midwives. I had 6 providers at my practice. One of them was going to catch the baby, right? And I didn't know who it would be. And in the practice, there are things that they routinely do. So it is recommended by the ACOG, which is the American College of Obstetrics and Gynecology, to recommend induction at 39 weeks. That's for every pregnancy, whether it's healthy or not. And we have an epidemic in America of induction. We have an induction epidemic. 20 to 40% of women are going to be induced, and half of those end in C-sections. And our C-section rate, especially in Western New York, is incredibly high. They say it's because we eat fattier foods and all these things, but I don't believe that. We live a more sedentary lifestyle because we're inside while it's snowing for 9 months out of the year. Oops, I don't know what their reasoning is, but we have an epidemic, and medically necessary inductions are awesome, but that's just one example I'm going to use as what I mean by individualized care. So when you go to a practice that has like 6 doctors, well, at 39 weeks, it's 39 weeks, we typically recommend induction. Okay. So is that just something as my practice that you guys always do? Or is this something that is medically necessary for me? Like, does my baby need to get out at 39 weeks? Like did the timer go off and like it needs to get out? Or can it keep cooking? Like, that's what I was like, personally, if I had been induced at 39 weeks, I know I would have had a C-section because I kept her in there for like 3.5 more weeks, 3 weeks. Like, that is the most crucial time for a baby to finish developing. Is this medically necessary for me, or is this common practice at XYZ weeks? So that's something you can get comfortable saying is this medically necessary for me, or is this just something that you typically always do? So, do we understand why medical professionals ask us to do certain things? Why are we changing plans? Is it based on necessity or convenience? Is it convenience for me as the mother, or is it convenience for the doctor? We just got done with Christmas, and that is the number 1 week of the year that babies are induced. It's a very common week for babies to be born because nobody wants to be in the hospital for Christmas. I understand that. But maybe your baby wants to be in the hospital on Christmas. I don't know. Maybe. I mean, it's up to your views and what you want to do, right? So, milestones during pregnancy. There are certain things that professionals will look at, and if you're not hitting X on the growth chart in your ultrasound, well, maybe you have this or that, and there are reasons for certain things. And I also want to remind you that doctors are not demons. They're not something to be like demonized. They really see a lot of crap, right? So they don't just see they don't just see healthy pregnancies. Like, the whole history behind an obstetrician, it was created because there were high-risk pregnancies. And then we all just started seeing OBs. Like, why don't we all just see a midwife unless we need to see an obstetrician? I don't know. Because there's not as much money in natural childbirth. Did I say that out loud? So I do want you to know, though, that doctors have seen a lot of things. So their whole goal is that if they can mitigate the risk and they can have a healthy baby, that is their top priority. But all interventions come with risks. So, are we informed and educated about why I would want XYZ and why I would not want one of these interventions? And as long as we understand the benefits and the risks, and we're willing to accept the risks, and as long as we are making the decision, we're not being coerced or talked into doing something, then we're in control of our birth and we have informed consent. And I think that is what matters most. Women who have said they are satisfied with their birth had 3 things. They felt supported by their provider, they felt supported by their partner, and they felt like they were in control and had an active involvement in the childbirth process. So they were making the decisions. At the end of the day, even if you don't want an epidural and you get one, own it. In the moment, you needed that epidural. You were tired. You were in pain. You made the decision. Nobody came in. That's the one thing. I don't want anybody to come in and be like, hey, you can get an epidural. You can get an epidural. Take that pain right away. Get out of my room if you don't want one. You know what I mean? So that's the one thing. I don't want anyone to have a carrot dangled in front of their face 17 million times, like some people have that I've seen. And then, of course, you're going to take the carrot because you're tired and it freaking hurts. So if you want to be informed about birth, where are you getting your information? This is huge. First, let me list all the places you don't want to get information, okay? Well-meaning friends and family. Love you, but leave me alone. I don't want to know about all the craziness like my mom. Oh, they'll just cut you. Like well-meaning friends and family. How about my boyfriend's aunt? Take some sandpaper and rub it on your nipples. It'll toughen them up. That is called nipple trauma. That is the last thing you should do if you're trying to get better at breastfeeding. You are never going to be able to latch that baby because you're going to be in so much stinking pain. Like, so they mean well, but is there evidence behind what they're saying to you, or is it their opinion and their love for you about why they're saying what they're saying, right? My mom could have been very upset that I went over 42 weeks with Monroe. She has a very traumatic, history with birth, my mother. And so that probably took a lot out of her to watch me be pregnant for that long. And then also to not say, well, I just kind of didn't talk to anybody towards the end. But they mean well, but they love you, So Google is also another terrible place. Everybody Googles and then they think they're dying, Sometimes your providers. If you want to know what your birth is going to look like, look at the rates of induction, epidurals, the C-section rate at the hospital you're delivering at, the C-section rate at your OBGYN practice. That is a telltale sign of the chance or the percentage that your birth will go that direction also. It's a pretty good prediction how it's going to go with you having them as your provider. And common practices are not the same thing as medically necessary. So a lot of times they might say to you, well, it's common practice that we do this. Okay, but is there anything is it a medical necessity? Is it necessary for me, or is it just common practice? Because common practice has no evidence behind it. Usually that's their history of why they feel a certain way about doing XYZ, so that's why they do it and it's common practice. But good places to get information is the ACOG, American College of Obstetrics and Gynecology. They're online. You can Google them. You can look at research. You can look at so many things and resources on their website. The Cochrane Review is great. It is a online just research studies and clinical trials, and it's all evidence-based information. It's great. The Mayo Clinic has a lot of good stuff. And then evidencebasedbirth.com is one of my favorites. This was a nurse who left her professor nursing job to start her own thing because she had a very traumatic birth and was like, I don't think that's how it was supposed to go. And then she had 2 more kids, and it's just, she has an awesome story. Her book is called Babies Aren't Pizza. They're delivered. They're born, not delivered. But evidencebasedbirth.com, there's a little search bar. You can type in any topic and she'll bring you to research studies and things like that to get good information. So good information. You don't want opinions. You don't need to watch the news. You know what I mean? It's like watching the news. Like, where are you getting your information from, right? And then another book I really love, this was one of the first books I ever read, was the Bradley Method, Natural Childbirth. Yes, it talks a lot about, and what I mean by natural is like unmedicated vaginal birth, not a cesarean. But at towards the end, they talk about all these interventions and evidence-based medicine versus belief-based medicine. And they talk about inductions. They talk about what to expect with an induction, going past your due date. Oh my God, I hearted that. the dilemma, but, just so many good things. And so what this book did for me is it helped me understand what birth was going to look like if it was untouched, but then also what it would look like if interventions were added. So this was definitely a really good book. I loved. Goes over every intervention in depth, even cesareans. Okay, risk. I wrote a really great blog article about risk, and what I want you to know is that there is risk in everything you do. There is risk in leaving your house right now and slipping down the stairs and, living or dying. Like, there's literally, like, if you get in the car, like, the risk is probably higher than, whatever. So there's no such thing as no risk in birth. There's either high or low risk, but not all risks are created equally either. So only 15% of women are going to be actually high risk. So the World Health Organization says that the percentage of births that should medically necessary be cesareans are 15%. And I think in Buffalo it's like 50, 45, 41. It's like really high. So why? I don't know. It's fine. It's fine. So what I want to say is that just because your pregnancy is high risk, so maybe you have, like a friend of mine just had a baby and the baby had intrauterine growth restriction, IUGR. She only had like one artery going through the cord instead of two or whatever. And so the baby was a little bit smaller. Okay, that is risky, but she could still have the baby vaginally. How cool is that? So, like, just because your pregnancy is high risk doesn't mean your birth has to be high risk, if that makes sense. So you can also have a low risk pregnancy, but then your birth turns into a high risk scenario. So some reasons for risk, your doctor will say you have gestational diabetes. So the baby could be bigger, the baby could be bigger. Hypertension, your blood pressure, the blood pressure of you or the baby. A geriatric pregnancy, does that make you feel good? If you're 35 or older, you're considered geriatric. You're an old mom. But what I want to say about that is I think you having high blood pressure is a way bigger risk than you being 35, right? So not all risks are created equally. Preeclampsia can kill you. It's not funny. It's like really bad. They test many certain ways to figure out if you have preeclampsia. It could be your blood pressure, it could be protein in your urine. But that's significantly bigger deal than you being 38, So pregnant with multiples. If you have more than one baby in there, you're high risk. You're gonna have to have the babies at the hospital. Obesity. I don't even know why they list this as a risk, because honestly, obese or heavier set women have better birth outcomes than skinny women. Like, that's the evidence. So I don't know if is it a risk? Maybe. I mean, everything's a risk, right? You're too skinny. I'm just kidding. I don't know. Like, lifestyle choices, like smoking, drinking, that's probably not good. That maybe makes you a little risky. Your pregnancy history, that's a risk. Maybe you had, miscarriages or stillbirth or, whatever before. Like, that's a risk, right? Maternal health problems. If you have like a heart problem, like my neighbor next door, she physically had a heart problem. The doctor did not think her heart could handle labor again. She had this heart problem that she didn't even know when she had her son like 14 years ago. And then now she's pregnant again, and he's like, I recommend a cesarean. I recommend a C-section. And she did. She had a good experience. but there are maternal health problems, right? And then a breech baby. That's not 100% risky. There's like 6 doctors in Buffalo that will deliver a breech baby, usually only if it is, a subsequent birth, like it's a second, third, fourth birth, because you have the muscle memory and you've done it before, that, you can have a breech baby vaginally. I know that's crazy, but if this baby's breech, I'm going to try, whatever but as long as I know all of these risks and I make an informed decision and I feel supported by my provider and my partner and I made an active involvement decision, and that's all that matters. So, last thing about risk I want to say is that pregnancy is a sign of health. I heard this in my doula training over a year ago, and I really clung to that statement because my mom, as an example, yeah, she kept getting pregnant, but something wasn't it wasn't computing, right? Like, just because she could get pregnant, she couldn't stay pregnant. So becoming pregnant, it's a sign of health. Like, it's a sign that there's something right happening in your body. Like, you're healthy. But if something's not going right, it's a sign that maybe there's something wrong with your health, right? And so if my mom had had testing, she probably would have found out about her thyroid stuff decades earlier. Yeah. But I want you to know, if you're pregnant and everything's going well, it's a sign that everything's good in the neighborhood, right? All right. The cascade of interventions. This is, I gotta tell you really quick, my kid is Monroe Violet Parker, so mom's the real MVP. My mom got this shirt for me. So anyway, the cascade of interventions. What this means is that one intervention can lead to the need for more interventions. So if you use one method to induce labor and that doesn't work, you're going to go to another method, to another method, to another method, to a cesarean. So there's a cascade. And so each intervention we use is a tool. We always have tools in our toolbox. Don't be fearful of any of these interventions, because sometimes you need them and sometimes you don't. So let's learn about them as tools and help inform your decisions about which interventions you might need or not need. Some you want, some you don't want. And just know that, they're in your toolbox if you need them. So, induction, I've talked a lot about this. Obviously, you can probably hear my opinion in my voice, but there are a lot of reasons for people to be induced. Just you name it. There's just so many reasons for induction. But I just want to tell you what that looks like, right? So your cervix is where, there's the vagina, there's the cervix, and then here's the uterus up here, right? So the cervix has to dilate, but it also has to soften. Effacement, dilation. So 0 to 10 centimeters for dilation, and effacement is like 0 to 100% for effacement, softening, ripening. The cervix has to be ripe, meaning feel your earlobe. It needs to be soft, not hard like the tip of your nose. So it'll be like cartilagey, and then it'll turn very soft like your earlobe. 20 to 40% of labor is induced, and that number has actually doubled since 1990. So the National Library of Medicine says, there's a study in there called Saying No to Induction. And I just want to read this to you because it was something that I love, that it's evidence-based and not someone's opinion. It says, induction rates have increased dramatically. A childbirth educator wonders how she can help pregnant women say no to induction. This column describes the last days and weeks of pregnancy as vitally important for both the mother and her baby, ensuring the baby's maturity and the mother's readiness for labor. Women are encouraged to appreciate the last days and weeks of pregnancy and to have confidence that when a woman's body and her baby are ready, labor will begin spontaneously. This information, as well as knowledge of how induction alters the process of normal labor and birth and increases the possibility of having a near-term infant, is the foundation for informed refusal. So, I like that because I don't have this in here, but Pitocin is on the bag, it'll say synthetic oxytocin. So when you're in labor, your uterus is contracting during a contraction and it is like releasing oxytocin, which is like the love hormone, right? Makes you happy and all these things. Pitocin is not oxytocin. They label it and say it is. It's fake. You can't recreate something that's, natural, like it's man-made, right? So it does a very similar job, but it does not pass the blood-brain barrier. So when you are feeling pain, natural oxytocin works together with your body to reduce the pain, whereas Pitocin doesn't cross that barrier. So it's in your blood and your brain is feeling pain because it's not working together, if that makes sense. So that's just the one thing that I was really nervous about getting induced when it finally came to do it, because I didn't want an epidural. Like, I just hate needles, and I just am weird and want to see what I'm made of because I'm a weirdo. But I didn't want an epidural, and I thought for sure that if I got induced, I would need an epidural. If my labor had been more than 12 hours, I probably would have ended up getting one because, yeah, it's intense, right? So, I don't know. That's just my little thing about that. But, okay, so you have the dilation and you have the effacement. Dilation, I'm going to tell you, it don't mean no thing, okay? Like, I know that sounds crazy. Everyone's always so worried. They go in, they're like, all right, you're 39 weeks. Let's do a cervical check and let's check and see how dilated you are. Dilation doesn't mean anything. You can be 4 centimeters dilated for the last month of your pregnancy, like my neighbor next door. Or you could be 1 centimeter dilated for the last month of your pregnancy, like I was. Or you can show up to the hospital 4 centimeters dilated and you push a baby out 3 hours later. Like, dilation doesn't mean anything. The effacement is huge. So they'll check you and they'll be like, oh, you're only 1 centimeter, like the tip of my finger, 1 centimeter. Okay, what about the effacement? If you can get a centimeter, then you can feel how thick the cervix still is. And so thankfully for me, I was like 85% effaced when I got to the hospital. I was probably ready. I was probably about to go into labor any day. But because I was so softened already, the induction, the Pitocin, was able to really work. If you are still like 0% effaced, you are hard. You are, not soft at all. There are a few things that they can do. So prostaglandins are naturally occurring in the body. This is the natural way to soften the cervix. They're naturally occurring in the body to induce labor and promote uterine contractions. The uterine cells produce them, and they're also in sperm. So that's why sex is a natural way to induce labor, because there's 10 times the amount of prostaglandins in sperm than there is in cervidil, which is one of the things that can be inserted into the vagina. Prostaglandins can be applied topically as a gel, or you can take a pill by mouth. So cervidil is something that is inserted into the vagina to soften and ripen the cervix. It's usually on kind of like a tampon insert, and it can be removed with a string if for some reason your body's not tolerating it well. Prepidil is something very similar to that, and it's applied with a syringe. Both of these things are usually very effective, and they're considered less invasive than other methods. So the only thing that would happen is if you went into the hospital to get induced and you weren't very soft at all yet, they would start you on a cervical ripening agent, like one of these things we're going to talk about, to soften you before they start the Pitocin, because Pitocin is pretty intense. So they want to make sure you're softened, or what are we doing? Where you're like running into a brick wall and you're not getting through it because you didn't get the grout out first. You didn't soften the brick. You know what I mean? So the mother has to remain in bed and monitored continuously after administering this. Some of the potential side effects are nausea, fever, possible fetal distress due to hyperstimulation of the uterus, higher C-section than the tablet form, increased risk of infection. Rarely severe allergic reactions or uterine rupture has been reported. Like that's a common side effect for like any method of induction is uterine rupture, but it is a lot lower than you think. Cytotec is another thing that they can do to soften. You can take it orally or as a vaginal insert. Once it's in there, though, it can't be removed. It's fast-acting, effective. There's a lower risk of cesarean with Cytotec compared to the Cervidil. Some potential side effects are also, again, fetal distress, risk of infection. Anytime you're putting something into the vagina during labor, you have a risk of infection. Rarely, you could have a uterine rupture, an embolism, shock, hemorrhage, or death. It's okay. Our maternal mortality rate in America is so high anyway, so what's one more thing? The Foley catheter. So this is another thing that they can do to soften, ripen, dilate the cervix. It is like a little balloon. It is inserted like a catheter into the vagina with a balloon attached to the end. So it goes, say this, you have to be at least 1 centimeter dilated because they can't get it in if you don't have any opening, right? So it's going to go in and then goes a little bit past into the uterus area, and then they blow it up a little bit. And it can blow up as big as 4 centimeters. So it's placed at the cervix and the balloon is then inflated. Usually it's like inflated on both sides, so it's putting pressure on the cervix to make it soften and dilate. And then once you've reached 4 centimeters, it'll fall out. So that's how they know that you're 4 centimeters, is because it fell out. It's very effective. It doesn't use hormones, so it won't have as many side effects or risks. I have heard it's painful, but yeah. So some potential side effects are increased risk of infection, B.R.A.I.N, which is premature rupture of membranes. There's like a 9% chance of that happening. We'll talk a little bit about breaking your water in a little bit, but if you don't have contractions and you're in the hospital and your water breaks, then you're kind of on the clock for what they think you're going to have an infection, and they think all these things, and they want you to have a baby within a day after your water breaks, but it's the risk of infection and everything is actually much lower than they make it sound. With the Foley catheter, another risk could be incomplete dilation, cervical swelling, and pelvic pain. So another thing that could induce labor is sweeping the membranes. This is something that I had done twice. Usually you'll know within, they say 48 hours, but I was told like 24 hours. You'll know within a day if it did anything. Sweeping the membranes, or a cervical sweep. So you have to have consent from the person giving birth that you're allowed to sweep their membranes. I know that sounds crazy, but sometimes there are some obstetricians, and it's called obstetric violence. Like, if they're giving you a cervical check to see how dilated you are, they can't also just be like, oh, I'm going to sweep your membranes while I'm up here. No, because like some potential side effects, they could accidentally rupture your membranes. They could accidentally break your water. It's, for me, was very painful. There was a lot of discomfort. So you have to consent to if you want that, you know. The doctor or the midwife is going to use their finger and they gently pull away the outermost layer of the amniotic sac from the wall of the uterus. So you have to be at least 1 centimeter so they can actually get their fingertip up in there. But then they just are going to sweep around the inside of like the cervix where it's inside your uterus a little bit to try and rupture those membranes, because there's little capillaries, you know, like veins in your cervix, and when you start to see a little bit of like a bloody show or like mucus plug, and you start to see like a little bit of like color in your discharge, it's a good thing towards the end of pregnancy, because it could mean that your capillaries are starting to like break open a little bit and your cervix is starting to ripen. So it's actually a good thing. Sweeping your membranes is an outpatient procedure. It's considered non-invasive. They just do it right there at your OB/GYN office. It's not a no-turn back procedure. So like once it's done, it's done. It may help your body release the prostaglandin hormones. You could experience spotting or cramping afterwards. You'll know within 48 hours if it's going to promote labor starting. The science behind it is that you're less likely to have a medical induction if you get your membranes swept. And then a cervical massage can also be offered if the cervix isn't dilated at all. So even if the OB or the midwife just puts a little pressure up on your cervix, that could help do some things too. So if you swept your membranes, you had the cytotech or the Cervidil, or you had a Foley catheter balloon, and you are ripened, now we can give you Pitocin. So say you haven't really done anything yourself yet, and they're like, okay, we're getting things going, so we're gonna do Pitocin. Okay, well, make sure your doctor doesn't say it that way. Like, I don't know, we're gonna do this. No, like, how do you feel about doing this? Like, can I just feel like I'm not having things done to me and I'm actually like a part of this? Like, anyway, that's how I feel about interventions, is I just want you to feel like you are informed and that it's not something that's just happening to you, that you are consenting because you know what these things are, you know, and you're not being told like this is what we're going to do. So with Pitocin, it is synthetic oxytocin. It's a hormone that causes contractions. It's administered through an IV. The dosage is monitored. It can be increased, decreased, stopped at any time. One thing I want you to know is, like, when I went in, they said, hey, every 30 minutes we're going to up it by like 1. I don't know if it's a milligram or what the actual dosage is, but we're going to up it by 1. We can go to 20. I was like, okay. And I think I got to like an 11. We ended up getting to like an 11. But there was one time she came in and like, we're going to up it. And I was like, can we not? Can we not up it right now? Because I think I was at like 9 and the contractions were like really intense. She's like, yeah, we don't have to. Like, because once your contractions are established, they don't really need to do it anymore. Like, I didn't know this at that point, that like, because my contractions were so like rhythmic, that they probably didn't need to up it at all. But yeah, so you should know that you can wait to increase the dosage. If you need a little time, you can always wait. So don't forget that. They're going to increase it every 30 minutes. Depending on your provider, their max is either 20 or 30. I made it to an 11. The FDA, I want you to know, whether or not you believe the FDA or not, because they don't regulate vitamins, like the most healthy thing in the world. But anyway, FDA has declared that Pitocin is not to be used for inductions for convenience or scheduling reasons. meaning elective inductions. That's why if you go to the hospital to get induced and your blood pressure's fine and your ultrasounds looked great and the baby's fluid level and everything, you pass everything with flying colors and you show up and you still go in for an induction, they're going to say, I need you to sign this paper for an elective induction because there is not a medically necessary reason for you to be getting this induction right now. So, because the FDA it's not approved for that because there's no reason for it. You know what I mean? So, some potential side effects is that 20% of inductions they're not gonna work with the Pitocin. It could cause contractions to be too strong, long, or cause fetal distress. That's why if you are getting induced, you will have a monitor for the baby to monitor baby's heart rate. They can see during a contraction the baby's heart rate should also be going up. And if they're decelling, then they're not handling it well, so they can stop or keep it at a lower level, and then hemorrhage, anything you're doing to the body that the body isn't doing itself can cause side effects. The one reason I really don't love Pitocin is because when I talk to NICU nurses that I know personally, and I ask, this was 2 people in particular, like, well, why, what's the main reason why those babies are in the NICU? And they say unnecessary inductions or inductions with Pitocin. I'm just like, well, then why did we do it? Like, I don't know what the reason was, but with Pitocin, you are making your uterus contract and you're making it do something it probably has never done before, and then also like not that strong. So it can cause your uterus to rupture, or it can cause your uterus to hemorrhage after you have the baby. So just those risks are lower than you think. I don't know the exact number right now, but they're there. And so just be informed that could happen. And let's talk about the A.R.A.I.N trial. So this was a randomized trial, and they did induction versus expectant management, which was just stay pregnant till you go into labor naturally. And they say that inducing all women at 39 weeks, regardless of medical need, reduced the rate of C-section. The trial was kind of skewed. So all OBs and midwives today are told by the American College of Obstetrics and Gynecology, ACOG, to recommend induction at 39 weeks, or to offer it, because of this A.R.A.I.N trial. But the evidence behind this trial, like, a lot of women ended up getting induced and not staying in that expectant management because they were like 41, 42 weeks and they were just like done with being pregnant. So they ended up getting induced anyways. So if we don't know what would have happened, we don't know if their C-section rate would have been increased or decreased because we didn't let them go into labor naturally, if that makes sense. So this trial is skewed. I don't love the evidence behind it. I don't believe 39 weeks. I don't believe that this study was enough to offer induction for every single woman at 39 weeks. But if you are offered, it's because of that A.R.A.I.N trial, and you can look it up online. Make sure you're going to a credible source to get the evidence, and just know that there's other things you can do. Like, I know towards the end of pregnancy, some people want to be done. I felt so great with Monroe that I literally kept saying, I could be pregnant for another year. It's probably why I wasn't going into labor. But like some women, pregnancy is really hard. Like I puked till 35 weeks with Monroe, so I felt really good at the end, minus the heartburn and the acid reflux in the middle of the night. This pregnancy is a lot harder than Monroe's, but I also like, I don't know, I want to be pregnant as long as I can because I know that's what the baby needs and that's what my body needs to be ready to deliver and to have a, you know, a good birth, you know? So as much as some women just want to be done with it at the end, I urge you to know you're still pregnant for a reason, you know? And as long as everything's looking good with you and baby, that baby needs you to be pregnant just a little bit longer, okay? And it's hard, I know. But as soon as the baby comes out, the puking stops, the heartburn stops, the acid reflux stops, and then all your hair will fall out at like 4 or 6 months postpartum. So it's just like all these any terrible symptoms that you might be having, they're actually going to go away the second the baby comes out. It's insane and so frustrating. But all right, those are all the medical ways to induce labor. Here are some natural induction methods. Ta-da! I know, they suck. They're terrible. With Monroe, I never ate them. I tried, but I had some with pits. These I found at BJ's. They're pitted. They don't have pits in them. And they taste much better. And I don't have to chew around like a seed to get the meat of the date. You can put them in smoothies. You could make low protein balls and put dates in them. Dates are the one thing that I have found with evidence online of helping support your cervix while giving birth. Crazy. So 2 dates a day, every day. I don't know when to start it during pregnancy. It's not going to induce your labor. It's just going to help get your cervix ready. Nipple stimulation. I don't like them touched. Could help. It'll release oxytocin. So you could put a pump, like a breast pump, if you wanted to pump. You could put a pump on. It'll stimulate your nipples. I tried it. So I'm going to list all the things I tried. I tried putting my pump on, and I cried. So Rory put my pump on. He'd be so embarrassed if he knew I told you this. I don't think he cares. He put my pump on because I was crying that I just did not like the way the pump felt. And I was like, how am I going to breastfeed? How am I going to pump milk for my baby? Like, this is so awkward and terrible feeling. And so he put the pump on, and it was a funny memory on our couch. But nipple stimulation could help. It could induce labor by releasing oxytocin. Red raspberry leaf tea. They sell it at the store. It has to be red raspberry. Can't be raspberry leaf tea. It has to be red raspberry. There is a brand, like a pregnancy brand, that you can also get. But Wegmans does have one brand of red raspberry. Pineapple. They say pineapple helps with your cervix. I had a whole can of pineapples. I'm not sure if it worked or not. Acupuncture. So I went to induction acupuncture at a friend of mine does it, and there's like 4 different pressure points. That's why if you ever get a pedicure or a foot massage, there are a few places on your heels and feet and calves that they really can't touch late in pregnancy because it can induce labor. I had it all acupunctured. I don't know if it did anything because I ain't going to labor, but we'll see. Blue or black cohosh, it's a supplement. Evening primrose oil and clary sage oil. I'm not going to huff this right now because I shouldn't be huffing it at 33 weeks, but it smells so good. And you could just apply it on pressure points. You could put it, there's like a pressure point right here for induction. There's a pressure point. Oh Why would I do that? There's a pressure point like on the back of your heel or something. There's a pressure point like here, whatever. There's a pressure point on your like pinky toe. You just smell it. I don't know. We don't know if it works. Maybe it does. Maybe it doesn't. I don't know. It's different for everybody. An induction massage. I also had a massage, and she really rubbed all those points that were already done with the acupuncture. Felt good. Don't know if it worked. Like I said before, sex helps. It helps especially if sperm is released, because the prostaglandins in sperm can help ripen your cervix. Walking is huge. I know the last thing you feel like doing right now is walking, but curb walking is super important. Curb walking, you're putting one leg on the curb, one on the ground, and you're walking and you're stepping up onto the curb and you're stepping down, stepping up, stepping down, and then you're going to go on the other side. You're going to be up and then down, and then step up and then down, and then step up. And the tilting of the hips is going to help get the baby engaged down into the pelvis to apply pressure on your cervix to hopefully dilate, soften, all that jazz. Spicy foods. Could be an old wives' tale. Spicy foods might work though. And then castor oil is something that your obstetrician probably would not recommend, but if you are in more of a holistic practice, castor oil is sometimes recommended by midwives. It not only releases baby from body, but also all bodily fluids. So it kind of unnaturally works the same way your body wants to make room for baby. So puking, peeing, pooping, we are going to get everything out of our body to make room for the baby to come out. And we don't want to have to go to the bathroom, because that takes energy that your body needs to birth a baby. So castor oil kind of works in that same way. I never tried that, but I did try almost all the other ones. I don't know. And then we had Pitocin. So some potential side effects of the medical inductions are the risk of infection, having a longer labor, increased use of meds, increased interventions, increased dissatisfaction, increased morbidity, and challenges breastfeeding. So sometimes, you need a medical induction, but usually once you start down the road of getting one thing, it'll lead to another. So just know that. And even if you try all the natural ways, they're not going to work unless your body's beginning to go into labor. So if your body isn't going into labor, those natural things aren't going to help. Like me chowing on dates all day long is not going to work. Okay, so then I want you to know the Bishop score. This is something when you get to the hospital, you should ask, what's my Bishop score? It's a great resource when considering if you want to get induced. Your dilation, this way. Your effacement, this way. The cervical consistency, is it soft? Is it hard? Your cervical position. Sometimes people's uteruses are tilted backwards. When it's time for labor, your cervix is going to tilt forward so that the baby can have a better descent out. Crazy. And then the fetal station. And what that means is baby, I love this thing, this is, let's look at the back of the butt. These are your, right here, there. These are your Ezekiel spines on your butt. You can feel them when you sit. They're called your sits bones. And this is considered zero station. So if the head of the baby is still super high up in here and we start an induction, like what are we doing here? You want the baby to be here, engaged into the pelvis so that it can put pressure on your cervix. So knowing your Bishop score is important, because most first-time moms that get induced, like 50% of them are going to have a cesarean because of their Bishop score. So I'll link a website where you can do this at your last doctor's appointment to be like, hey, I want to know my Bishop score, or I'm not showing up for that induction unless you think it's medically necessary. Okay. All right. A few more things. We're going to talk about pain management and then breaking the water and monitoring and cesarean. Okay, let's see here. All right. So pain management. Most of you are probably like, I can't do pain. I hear childbirth is so painful. Well, it's nothing like the movies. So your water doesn't break and then you push the baby out 3 pushes later. There is some sort of pain. It's pressure. It's intensity. Some people don't view it as pain. But what I want you to know is it's only for 60 seconds. You can do anything for a minute. And the cool thing about contractions is that, yes, they are intense in the moment, but if you are figuring out like hypnobirthing or breathing exercises or relaxation techniques, that can really help with natural pain management until you get an epidural, or maybe you don't get one at all. Yeah, because the cool thing is, yeah, it's going to last for 60 seconds, but you're always going to get a break. You're always going to be able to get like 2 to 3 minutes, 1 to 3 minutes in between. So, an epidural, what does this look like? So I was going to grab strings and I totally forgot. So you would have 1, 2, 3, 4, 5, let's say 6 pieces of string. Okay, pretend we have 6 pieces of string. It's a really great visual. When you get an epidural, you're going to have an IV in your arm. You have to. You're usually going to have an IV in the hospital regardless, but you're going to have an IV. Then you're going to have a pulse ox, which is for your oxygen, your blood oxygen level. That's going to be on your finger. Then you're going to have a blood pressure cuff. So there's 3 things hooked up to your arm. Then you're going to have a belly band for the baby's blood pressure. You're going to have a contraction band on the bottom of your belly to top or bottom. I think the bottom's the baby and the top is the contraction band. So you have 1, 2, 3, 4, 5 things hooked up to you. And then you have a catheter, because if you get an epidural, you can't walk. You have lost your ability, but you've also lost your privileges to walk around and move about the cabin. So you have to have a catheter, because how are you going to get up to go pee? And usually one of the main reasons why the baby isn't coming down is because your bladder's in the way and it's full. So if you have a catheter, it's a constant, release of fluid so that it's making room for baby. So your epidurals are going to take 30 to 60 minutes. You go in with an anesthesiologist, or the anesthesiologist comes into your room, and they're going to be asking you questions while they're doing it. They're going to ask if you taste a metallic-y taste. They're going to ask all these different questions to see how they can adjust the medication to make sure you have a good dose. You're not too dense, too heavy of an epidural, or too light of an epidural where you can still feel everything. And then they're going to place the catheter also. Nobody is allowed in the room with you other than your nurse. Your partner's not allowed in there. Usually your doula is not allowed in there. Sometimes they will allow it, but it's very few and far between. I've never seen it before. I do know some doulas who have great rapport with hospitals, who've been there a million times, and they'll be like, yeah, you can stay in with her. But I want you to think about, like, your partner. They don't know any of us, right? So, like, the last thing they need is your partner to have come from the bar to meet you at the hospital, and they're a little tipsy, and they push the bed. Like, they tap the bed and move it while they're trying to place this catheter in between your spine. So that's why, like, extreme case scenario, that's a example of, like, why no one's allowed in the room. They just want people, like, the rooms aren't that big anyways, but partners aren't allowed in there. Sorry. Your epidural, I want you to know, it can be given at any time. So if you're under the impression, well, But when can I not get the epidural anymore? Like, oh, I heard I can't get it after 8 centimeters, or I can't get it after 10 centimeters. You can get an epidural at any time. The only time you can't get an epidural is when the baby's head, they can see the head. And this baby's going to be out before they can even, it takes 30 to 60 minutes to place the epidural. So if they know that like the baby's low and engaged in this pelvis, okay, you could be 10 centimeters dilated, right? You could be 10 centimeters dilated and fully effaced, but baby could still have a very high station and be up high in the pelvis. If they're down here, they're going to be out soon, but your uterus has to contract to get this baby to come down into the pelvis. So even if you're 10 centimeters, you can get an epidural because your pushing might take a couple hours. So anyway, that's just an example of that. 85% get complete pain relief from an epidural. 15%, it does not work 100%. 3 out of 4 people get an epidural, and 88 to 99% of hospital births will get an epidural. There are some cons. You can't get up anymore. So without gravity working, like, because usually now you're like either on your back or you're on your side, and like if you could like stand up and walk or stand up or like sit on a birth ball or just like get up to go to the bathroom, gravity is going to help the baby put pressure on the cervix, producing oxytocin. So if you don't have gravity, the baby puts less pressure on the cervix, you produce less oxytocin, and it slows down your contractions. So that's why we want to help you get to active labor. Active labor used to be considered 4 centimeters. Now it's 6 centimeters because women were getting epidurals at 4 centimeters and then their contractions were slowing down. So now we're giving you Pitocin to get them going again. So now you can see how this cascade of interventions starts. So if you can wait to 6 centimeters, wait until you're in active labor to get an epidural, the chance of it slowing down your contractions decreases. Another con is that you might get a reduced urge to push, and you will have a longer pushing phase. The cool thing about the last birth I was at, I said to the doctor, because this girl had already had a baby before, and she wanted to not get an epidural, but she ended up getting it. She made the decision in the moment. Great decision for her. She needed some rest. And she couldn't feel what her pushing was doing. She's like, it's so much different than my first because I have an epidural. I can't feel it. So I like turned to the OB, who's never had a baby before. And I was like, can we turn it down a little bit? And well, if she wants to. And I was like, if you turn it down a little bit, you might be able to feel a little bit more pressure to feel what your pushing's doing. Do you want to do that? You can always turn it back up. Sure. Can we turn it down a little bit? Finally, after asking like 2 or 3 times, they turned it down. I said, how long is it going to take like for her to feel a little bit of a difference? She's like, less than 5 minutes. 3 pushes later, she was like, oop, yep. She can 100% feel what that pushing's doing now. And then she pushed like 4 times and the baby was out. It was awesome. So you can always turn it down. But that's the cool thing about a doula is they know the medical side of things where they're able to like convey to you what could happen and help you advocate for like what you want, you know. A con is that they can't go through a full color tattoo. So if you have a tattoo down there, they can't go through color if it's right over where they do the epidural. And then some pros is that it'll give you rest and relaxation. It'll help you cope with the sensations of labor. It might be able to help relax your cervix if it is swelled and swollen. Most women who end up getting epidural, they get it because they're so stinking tired. They just can't stand themselves anymore. They're tired. They've been in labor for a long time, you know. But these potential side effects are huge, and you need to know them so that you can weigh the risks before you get one. Spinal headaches, not fun. You'll know if you have a spinal headache if you wake up the next day and you can't even sit upright for like a week or two. The reason that happens is because this is like your spinal fluid, and they put it right in there and they place it right there. If they go a little too far, they're putting the medicine into like, I can't think of the word of it right now, your Durham, and then you have to have that part patched. It's called like a spinal patch or a spinal block, so that it doesn't travel up to your head and give you this terrible headache. They say that those are really rare, but I've had a few clients that that's happened to, so you just have to know that that's a chance. Another side effect, it could give you only partial pain relief. A lot of people I know, they feel everything on one side of their body, and then the other side's completely numb. Yeah. There could be a reduction in your blood pressure. Usually this happens for everyone who gets an epidural, but it goes back to normal after a couple minutes. Slowed labor, because you're confined to the bed, the lack of movement and the lack of gravity to aid in labor, it could slow down your labor, could give you a fever, and it could also paralyze you. So those are just some things that could happen. Say you want some pain management, but you don't want an epidural. You could get new B.R.A.I.N or opiates. This is good for people who don't want an epidural, or if there's a really long line to get an epidural, because there's usually only like one anesthesiologist on at a time. And if they're in a C-section or they're bopping around because a bunch of people are in labor, you could get this for the time being. Only thing is, the baby should not be born within 2 hours of taking, because new B.R.A.I.N is an opioid. So it would be in the baby's system when they're born. Baby can be born with difficulty breathing, and mom is high as a kite. That's what I was told. So I've actually never had anybody use this, but it's something, that you can use. But apparently it makes you feel high as a kite. Another thing you can do is laughing gas. It's temporary for contractions. It's only going to last 2 to 3 breaths. It wears off very quickly. There's no side effects, and it's good for people with anxiety. So they say like 30 seconds before the contraction starts, take in a breath of the laughing gas, and then by the time the contraction has started, it will help with that contraction. That's an option. And then there's also something called a spinal. So this is like severe, crazy, last case scenario. This is complete sedation in serious situations. It is surgically removing the baby. It's going to last 1 to 2 hours, and then it'll wear off. But this is where they would intubate you, and they do a spinal, which is more than an epidural. And you're completely not completely sedated for that. Cesarean. So that's like worst case scenario. All right. I have a couple more things. Failure to progress. This is something that if you are in labor and you get some interventions that slow down your labor, or you're a first-time mom and it's taken a long time because your body's never done it before, and labor is usually like a 24-hour thing from start to finish. So FTP is failure to progress. It's also called prolonged labor, and it happens when the labor slows and delays the birth of the baby. For first-time moms, the average is 20 hours of labor, and if you've previously given birth, it's about 14 hours of labor. If the failure to progress happens during the first stage of labor, which is that 0 to 6 centimeters, it can be exhausting, but it does not cause many complications. But if it does happen during 6 to 10 centimeters, then this could be a cause for concern, because 0 to 6 centimeters is going to take the longest amount of time, but 6 to 10 should take less time than 0 to 6. So the number one reason for a long labor is a male-positioned baby. Best thing you can do is keep switching positions. Every 30 minutes, get on your right side, get on your left side, stand up, get on a birth ball, get on all fours, do a side-lying release on both sides. There's so many things. Go pee every hour. That's getting you up. That's getting you moving and changing positions. work with your nurse or your doula to get the baby in a more optimal position to descend. Baby needs you to help to make room in your pelvis. And if you're just laying on your back for 12 hours, more times than not, it's going to end in a cesarean. And if you're okay with that, then that's fine. Failure to progress, I don't love, because I think it's supposed to be called failure to wait. That ARRIVE trial also noted that Pitocin must be given for 12 to 18 hours after your water's broken before deeming the induction a failure. So if you haven't had Pitocin for at least 12 hours, then you can't say you failed, your labor failed to progress. You didn't wait long enough. So, like, there's a ton of reasons for slow labor. Your cervix could need more time to soften. You could have pain medicine that is slowing things down. You could have a really big baby. Your pelvis could be a little smaller. It's more narrow. Baby's got to figure out how to navigate out of there. You could have multiples. You're carrying more than one baby. Your uterine contractions could be weak. You could have worry, stress, or fear in your body, and like your body's not going to want to do anything if you're feeling stressed out or scared. And then 1 out of 3 C-sections are done because of this failure to progress. And the leading reason for emergency C-sections, vacuums, forceps, is because of failure to progress, which I think failure to wait is a better way to say it, but what are you doing in the waiting? You need to be moving. You need to be doing things while you're waiting, because if you're not moving and helping baby to descend, then yeah, you're not progressing, because you're not doing anything to help that kid out. So the best way to get labor going again is to go for a walk or change positions. So, hey, I want to turn my epidural down. I want to be able to stand out of this bed. Can you turn my epidural down? Turn it off. They can do that. It is your birth, you know. All right, breaking the waters. Amniotomy. Breaking the water. That's what it's called. So your cervix has to be at least 2 centimeters dilated, and the baby's head needs to be against it. Because breaking the water, there is a very low risk chance of this happening, but it happens more often than I hear about. If the baby's still high up and they break the water, there's a chance that the cord could prolapse out before the baby's head. And then the baby is going to rush down onto the cervix and put pressure onto the cord, cut off supply of blood and oxygen to the baby. Now you need an emergency cesarean to get the baby out because we broke your water. So that is why the baby's head needs to be against the cervix, so that there's not that chance of the baby getting forced down with the pressure of the water breaking. It's a plastic hook, looks like a crochet hook. It's inserted into the vagina to gently open up the amniotic sac. You're no longer going to be able to get into the shower or the tub to help with pain. And now you're on the clock and monitored. So they're going to monitor you for infection with like your temperature and stuff like that. There are strict time limits on labor progress at the hospitals. So they want to see that you are like progressing in your labor, especially after you break the water. So if you aren't very dilated at all, there's pluses and minuses. Sometimes the water breaking can really help you dilate, and other times it might not work in your favor. So the fluid color is going to provide limited information, because if you break the water and there's like a meconium stain, which is like the baby may have a bowel movement, it can be normal or it could be abnormal. So it can either really scare the doctors, or the doctors can be like, well, this might not be abnormal. But like 9 times out of 10, they're going to be like, oh my God, the baby's got to get out because it had a bowel movement. You just don't want them to inhale it on their way out. That's like the main issue. So some potential side effects are higher risk of infection. You're inserting something into the vagina. It also does not have any benefit in shortening labor if it's your first time giving birth. So there's no evidence behind it shortening your birth if it's your first birth. Cord prolapse is 0.2% of births. It is rare. Baby could come down into the pelvis in an awkward position. So this is called asynclitic. When the baby comes down into the pelvis, you want it to come straight, but if it comes down with its head, all right, so this is the head and it come down. Well, if it comes down tilted like this, it can't. I like the water to stay until it doesn't want to stay naturally, because the fluid helps baby, because I don't know if you noticed, the baby turns like twice as it's coming out of you. The head needs to go in and then the shoulders need to go in and then it comes out. So if there's fluid and the contractions are pushing the baby, then the fluid can help the baby to move and to turn a little bit easier than if it's dry, The heart rate could fluctuate for 1 minute. That's to be expected. And then you no longer have that cushion, so the contractions can be more painful. And then posterior babies are when they're facing like sunny side up. So like when the baby comes out, you can see their face. You're supposed to see the back of their head. And if they come up like sunny side up babies, it's going to be a longer labor. So if they had fluid, the fluid might be able to help them turn their head to get into the pelvis to be in a more optimal position for birth. So you need to let your provider know if you don't want to have your waters broken. Once your water breaks, whether it was naturally or not, your contractions will get more intense. It's just what it is. So that's something to think about. Episiotomy. Oh, they're just going to cut you. Okay, mom. So 86% of first-time moms are going to tear naturally. It just is what it is. You'll have like a first or second degree tear. 4% of tears are going to be like a severe third or fourth degree tear. But what I want you to know is an episiotomy is mainly used today for emergency situations for the baby. They need to get that baby out now. Sometimes the care provider prefers to cut it because if it's a straight line, it's easier to sew up. I think my doctor explained that mine was like an M or a W shape. Great. That sounds great. But research is that it's preferable to tear yourself for the healing and for pain. And there is an increased chance of that third and fourth degree tear. If you get an episiotomy, there'll be a little bit more healing time, a little bit more pain with the procedure and the postpartum. But episiotomies are much needed if they're medically necessary, okay? Continuous fetal monitoring. This can be done internally or externally. This is externally, you'll have a band on your belly, a band to monitor the baby's heart rate, and then another band for your contractions. The internal one is a little screw, a little spiral wire that is placed into the top of the baby's head. It's a fetal scalp electrode. Potential side effects. Either of these, the external one can provide a inaccurate fetal heart rate. Say you move or the baby moves and then they lose the baby's heart rate. This is one of the main reasons for cesareans, is because they keep losing the baby's heart rate. So it kind of causes more fear than needed. That internal little scalp electrode can cause a mark or an abscess on the baby's head. Obviously, there's a risk of infection with the baby or with you inserting anything in the vagina. Research, unfortunately, has not shown it has improved fetal outcomes. So an alternative would be intermittent fetal monitoring, which is like every 20 minutes from the outside, they get the baby's heart rate, you're good to go. So that's another option also. Assisted vaginal delivery. So this is forceps and vacuum. This is used when the birthing person is pushing. So when you are pushing, The vacuum or the forceps are going to gently pull and help guide the birth of the baby. You need a written consent for them to do this. There are strict safety criteria and guidelines. A local anesthetic or epidural is probably going to be used for your pain control. And then these aren't really used as much as people think. I think it really is for emergency scenarios where they're like, we are going to do a C-section, or we can try to get this baby out right now. What do you want to do? So they're very rarely used in the US nowadays. The only thing is, like, forceps are more likely to result in a vaginal birth than the vacuum. I can't remember how many times the vacuum's allowed to be used, because one of the risks is that it could cause a subgeal hemorrhage, which is where there's like blood between the skull and the skin of the baby's head from that pressure. They could cause urinary incontinence or fetal incontinence for you. It could cause painful sex or pelvic floor disorders. There's a higher risk of perineal tears and more pain for you. But they are they're needed when they're necessary, if that makes sense. All right. This is not something I love talking about, but I am really excited to prepare you in case you do need a cesarean section, C-section. My first ever client did all the things, hired a doula, did so much preparation, had a typed up birth plan, and 24 hours later she had an emergency cesarean. And what that means is it just wasn't planned. There's either planned or unplanned. And if it's unplanned, they label it as an emergency. But really, it wasn't an emergency. It was just like, hey, we didn't plan on this happening. So I want to now better prepare people for what a cesarean is going to look like and how peaceful it can be and how scary it doesn't have to be, because so many people, like 40% of people in Buffalo, are going to have one. So the World Health Organization says that only 10 to 15% of births should have a cesarean. Like, that should be the rate, because optimal maternal and neonatal outcomes, like the mortality rates of mom and baby, doesn't improve if the rate is above 10 or 15% of births. I think the US in 2021, 32% of births were cesarean, and New York State has the 12th highest rate at 34%. So look at your hospital, look at your provider, check out their C-section rate, and that's going to be the biggest independent risk factor of if you're going to undergo major surgery with a cesarean. And just make sure you find a provider that's going to support you in your birth. If I want you to know you can have an elective cesarean. This is your choice. If you had asked me a year ago, I want to have a cesarean because XYZ, I would have been like, oh my God, like, don't you want to experience childbirth? It's just like so amazing. And then I went to exactly a year ago this week, I went in the OR to an elective cesarean. Her first birth was super traumatic, and it was so redemptive. You know, the first baby got transferred to a different hospital, and she didn't know if it was alive. She was alive for 8 hours, and her second baby, she got immediate skin to skin. Baby latched breastfeeding. Her postpartum healing was so much better. And it was nice to see that her doctor supported what she wanted to do. And so you can have an elective one. It really is your choice. But if you're like me and you want to reduce your risk of having a cesarean, look at your hospital, look at the provider that you choose, and that's going to be your biggest factor outside of like a crazy medical necessity for whether or not your baby's going to be born vaginally or cesarean. And if you don't think your doctor's going to honor your birth preferences, bye. Because imagine how they're going to be in the delivery room if they're giving you red flags now prenatally. So it's never too late to switch providers. Never. Okay? Never. You can walk into any hospital in Buffalo and birth a baby, even if it's not where your provider is. You can just not call them and just go somewhere else. Anyway, just kidding. But seriously, like, that's how extreme. If you don't feel like you're going to be supported, then find someone that you think will, you know? Here are medically necessary reasons for cesareans. Placenta previa. Your placenta grew over your cervix. That baby can't get out through your cervix. Herpes outbreak. That baby doesn't want to come out through your vagina right now. Deformity in baby. That baby has to navigate the pelvis. Let's make it easier and take the baby out a different way. Placental abruption. Your placenta is abrupting from your uterus, you are hemorrhaging, and you could die, and the baby no longer has blood and oxygen. We need to take that baby out. Cord prolapse. That baby can't get blood and oxygen because the cord is being, pinned. We need to take that baby out a different way. Failure to progress. There are reasons why baby just isn't coming. We might never know, but maybe there's a reason that we don't know, and it's better to take the baby. Fetal distress. This baby's not handling contractions very well. We would like you to have a happy, healthy baby. We should take the baby. A male positioned baby, CPD, it's just funky. It's in a funky spot. You know, it could be breech. Why is that baby breech? Well, my sister-in-law has a heart-shaped uterus. Literally, it's like a bicuspid or something they call it at the very top of the uterus. The baby could not turn because it had this area at the top of it where the baby could not turn to get her head down. She didn't know that till after she had the cesarean. So it was just like, we never know why. We might never know why. Some babies just are breech and they never turn, you know? If you have multiples, you have more than one baby in there, maybe we want to take these babies a different way. Male presentation, meaning like not this side of the head is facing out, like the front of the head. Can you imagine you came out this way and you're supposed to come out this way? Ouchie for both of you. Preeclampsia. Hey, this could kill you. Like, no joke. Preeclampsia is no joke. I've had so many friends who've had it, and it's really freaking scary. And so we should get this baby out to keep you and baby healthy. If you have maternal health problems, if you request it, or if you have medical complications. Those are all the reasons why C-sections are medically necessary. If you have to have one, your body didn't do something wrong. You didn't do anything right or wrong. Sometimes babies are just born this way. And if you really wanted a vaginal birth, have a VBAC, vaginal birth after cesarean. You can have that next time. There's so many things you can do. Just find a doctor that supports you, and cesareans can be great. You are going to feel a lot of pressure if you are having one. Like they tie your arms like this onto the bed because they don't want you to feel that urge to it's like that phantom, like when people lose a limb and they feel like they can still feel it. They don't want you to reach towards your stomach. So anesthesia will come in there and make sure you can't feel anything. And then the baby's out quick. It takes longer to sew you up than it does to take the baby out. Like, you will feel pressure of them moving things to get the baby out. And it can be scary, but it's all normal. And your nurse will help you. They'll have a nurse up by you and your partner. The baby will go right to the warmer and they'll do some things, whatever. And then you can have skin to skin right there in the OR. And then they sew you up. There's I think there's 8 layers. And then you go back, and then a couple hours later, once you can walk, you get transferred to your baby mom unit room, and you're there for a couple days. So it's definitely very much needed when it's necessary. Last but not least, okay, you've learned about all the things. You've learned about all these interventions, all these things that could happen if birth doesn't go like they used to do it in caves. Whatever. So B.R.A.I.N, B-R-A-I-N. This is the B.R.A.I.N acronym, and you can use this to make decisions and feel confident in pregnancy, in birth, postpartum. This is how you can make every decision. So if they come in and they want to do XYZ, you can say, hey, can I just have 5 minutes? Can you come back in a few minutes? I just want to discuss this alone with my partner. Or can you give me 5 minutes? I just want to think about this first. You want to call someone or you want to Google something. Whatever you want to do, ask for some time. If it was an emergency, you would already be prepped in the OR for a cesarean. I'm just letting you know that. So you always, 90-something% of the time, have time to slow down to make a decision. B, what are the benefits of this intervention or procedure? What are the benefits for me and what are the benefits for the baby? Risk. What are the risks of this intervention or procedure? What's the risks for me? What's the risks for the baby? A, are there any alternatives to this intervention or procedure? How does this alternative compare to XYZ? Are they more gentle or is it more invasive to me and the baby? I, intuition. Ask yourself how you personally feel about the situation. You can listen to your head and your heart and your gut. But if you're listening to your head and your heart and you're not listening to your gut, I beg to ask you why. Because a mother's intuition is so heightened when she's pregnant and giving birth. It's literally like a mammal's response to have this intuition, this gut feeling, right? So just listen to your intuition. And then N, nothing. What happens if we do nothing? What happens if we wait? What if I say, not now? What if I say, can we wait an hour? How long is too long for me to decide? How long is a reasonable amount of time? Like, if they want to start Pitocin because your contractions slowed down, what happens if we just wait an hour? They can't tell you no. They really can't unless, there's a medical reason. So what are you going to do, though, while you wait that hour? Are you going to move? Are we going to get things going? Are we going to stand? Are we going to go for a little walk? Are we going to turn your epidural down so you can get on all fours? We got to do some things in this hour, because if you're just laying on your back, what's going to happen? You know what I mean? So B.R.A.I.N, benefits, risks, alternatives, intuition, nothing. You can use this to make all decisions. I think it's a great way to kind of go through your bases and how you feel about everything and to make an informed decision about all of these interventions. I really hope that this video that is so long helped you learn so that you're informed, so that now you can make your birth plan. But remember, birth is so unpredictable. So call them birth preferences, okay? You can have preferences. You can prefer to not have a cesarean. Okay, so then backtrack a little bit so you don't have that cascade. What are some things that you can do now? What are some things that you don't want to do for interventions that would lead to a cesarean? So I hope this really helps you make decisions. I hope it helps you put together your birth preferences. And I hope you have a very awesome birth and transformational, because it really was for me. And I hope you have a healthy and happy rest of your pregnancy. None of this was medical advice, but just know that you can find all of this information if you know where to look and you look at those credible sources. And birth doesn't have to be scary. It can be really exciting too. So good luck with everything, and thanks so much for tuning in.